Hello and welcome to Season 2, Episode 68 of the Physician Assistant Exam Review Podcast. This week we're going to be picking up with ENT and covering the ear. My name is Brian Wallace. I'm the host and creator here at Physician Assistant Exam Review, and it's so nice to have you aboard. I'm so thankful for each and every one of you coming, listening, participating in the show, and being involved in everything that we do here. Speaking of people being involved, I really wanted to thank the two people we got to interview over the last couple of weeks. Last week we had someone who failed out their first year of PA school, and despite that daunting thing happening to them, that terrible thing happening, they actually came out a lot stronger, a lot better, were able to help a ton of people, help the people in their class improve, and I think it really came out to be for the best, as much as that the whole thing sort of stunk. And then before that, we had Alana on, who discussed how she had failed the PANCE and didn't lose her job, but had a job lined up, and how devastating that was and everything she had to go through. That was in episode 61. And I recommend you go back and listen to those if you haven't heard those. They're really, really powerful interviews filled with amazing tips, some really good ideas, and also to help you get through this tough time when things are different and everybody's struggling a little bit in their own way. And it's a situation we don't want to be in when you're waiting to see if you're going to take your PANCE, where you're waiting to see if your rotations are going to come back online or when they will. You're doing homeschooling, which is difficult to learn this material with a professor in front of you, let alone trying to learn it on Zoom or through a recorded lecture. I know that can be really, really tough. So those two interviews are great places to go to feel a little bit better about some tough situations and see how it can help you to grow and help you become a better person, as much as it does, sometimes you don't want to hear that. Sometimes you just want to wallow and be upset, and that's okay too. But there are a lot of takeaways, a lot of habits you can build during this time, a lot of things we can do to improve ourselves, to get better, and to show ourselves that this is something you can handle. This is something you can do. So I just wanted to thank those two individuals for that, but I also want to thank all of you for tuning in, for being part of the show, for the iTunes reviews, for the emails, for everything that you do for me to keep me motivated to continue to do this show. I really, really do appreciate that. It's really been great. And I wanted to get that out right up front. I feel like I don't say that nearly enough, and I wanted to get that, like I said, just out for you guys before we moved on with the show. So we are moving through ENT, and this week we're going to start with the ears. In the next episode, we're going to finish the ears. It's kind of a short section. And one of the things I want you to take away, I actually recorded this morning, and all of the levels on the audio were all screwed up from when I had recorded the work from home, get all your work done video series. I used the same equipment and microphones and stuff, but I had to alter the way it works. So the thing I recorded this morning got totally lost and blown out. So I've been through this once already. So what I want to point out right up front, and I mentioned this a lot, but I think it's really the key to passing exams, to learning things, is understanding how things compare to other things. Understand how they're going to ask the test questions. Understand which things are going to be answer choices for which test questions. And what I mean by that is we're going to go through today the external ear, right? And the things in the external ear are going to be the things you find as the answer choices. So what I mean by that is, I'm stammering over this, but if you get a test question that clearly is looking for a diagnosis of something in the outer ear, they're going to list all of the outer ear and maybe some middle ear diagnoses. So you have to figure out how to separate all those. And we're going to talk about that a little bit as we move forward today. I hope that you can pay attention to that as we move through this, and I'll try to make it more clear as we go on. I don't think I did a great job there, but you'll see as we go. And as I go through the priming questions, you'll get a little bit better idea. So let's go ahead and start the ear and start with our priming questions. All right, number one, what is the most common cause of otitis externa? What is the most common cause of otitis externa? Name the three most common bugs that cause otitis media. The three most common bugs that cause otitis media. And what is the first-line antibiotic for otitis media? First-line antibiotic for otitis media. All right, so listen up, see if you can follow along and grab those as we go through this. I think you should be able to. The external ear, we're going to start with cerumen impaction is number one. Some of these, and like I said, since I did this already this morning, I have a better understanding for how this layout works. like cerumen impaction, and we will cover tympanic membrane perforation and a couple other things. I think you need to pay attention as you go through stuff like this. Do you really need to highlight and underline all of the things under cerumen impaction, meaning wax buildup in the ear canal? Well, not really. I don't think that you really need to spend a lot of time memorizing this, because I think there are things you can understand and things you can make super easy and things that you can see coming. And in this case, for impacted wax in your ears, it's pretty straightforward. One of the risk factors is people using cotton swabs and pushing the wax into their ears. How is this going to present? Well, you can get some hearing loss if it's all jammed up, or you may just see it on a routine office visit. For lab studies and physical exam findings, an otoscope, so you look in the ear and you see the wax build up. Again, just not complicated stuff. And then you do a hearing test to compare both sides. If the hearing is different in one side versus the other, that sort of thing. If it's blocked, it'll give you that information. Treatment. This is the one part that maybe you don't know. You can use different solvents. So hydrogen peroxide works, mineral oil works, glycerine works. If you have really hard crusted, thick, disgusting wax in somebody's ear, you may need to soften it up with some sort of a solvent. You can manually remove the wax. So you can do that with irrigation and flush it out, or you can use a blunt curette. A curette is like a little tiny spoon. It's got a little bigger cup and a little sharper angle on it, but it's basically a little tiny spoon. And then you could also use something like a right angle hook for removing that wax manually. So you're looking in the ear, you're trying to be as steady as possible, making sure you don't cause any more damage and create some trauma there. But you're going to use a blunt curette or a right angle hook and just scrape that stuff out of there. And that's it for cerumen impaction. So that's on the blueprint. But how are they going to ask a question on that? That's going to trip you up or fool you? I just don't see it happening. So I think you can handle this one. I don't think you need to make up an index card. I don't think you need to highlight anything under cerumen impaction. Next, we have otitis externa, which is also known as swimmer's ear. If you can think of this as swimmer's ear, it's easy to separate out from otitis media, which tends to be with little kids, 1, 2, 3-year-olds, that sort of thing. And that will help you to differentiate them. In the beginning, I talked about differentiating diagnoses. If you look at our priming questions, our only priming questions are on otitis externa and otitis media because it's the easy thing to write questions about. It's hard to write hard questions on cerumen impaction. That just isn't kind of a thing. So you want to think about otitis externa in relation to otitis media and how you would separate them on your test. But also if you're in the office, how would you separate them? So otitis externa, one of the easiest ways to think about it is to think about swimmer's ear, because that'll affect your age group and the pathogens, which you're going to talk about. So the most common pathogen is Pseudomonas, and a risk factor is just trauma to the ear. If you have an opening in the external ear, that's going to let bacteria get in, then this is an increased risk. Clinical presentation is pain, pruritus, and a foul-smelling discharge. Hearing loss can also be an issue. Lab studies of physical exam findings, pain with movement of the auricle, pinea, or tragus. On otoscope exam, you get a red swollen ear canal, right? Tympanic membrane moves with a pneumatic otoscope, and the eardrum is still intact. Treatment. Well, first of all, we want to stop this from happening. So don't put things in your ears. That'll help. Careful use of earplugs when swimming will help. And a drying agent after swimming may also be helpful. So something like a 50% alcohol or a white vinegar solution will work to dry out the ears after swimming. You can use an antibiotic here. So a mild to moderate case, you can use several drops of fluoroquinolones for a few days. So Cipro, afloxacin, you can do drops for about 7 days. Severe cases may require systemic antibiotics, and a steroid drop is optional depending on how bad the swelling is. If they can't hear, if they're having a lot of pain, that sort of thing, steroids can help to bring that down. One complication I want to note here, you can get malignant otitis externa, which is an osteomyelitis of the temporal bone. Remember, osteomyelitis is an infection of the bone itself. And that's a major, major problem because it's hard to treat that without removing the bone, or at least part of the bone. So osteomyelitis of the temporal bone, this is a complication that occurs usually in people with depressed immune systems or somebody at risk for an infection like a diabetic, something like that. There's usually some secondary factor here. And the big deal is this can be dangerous and can lead to nerve palsies in cranial nerve 6, 7, 10, 11, and 12. And these people get much larger doses of IV Cipro to try to take care of this. The last one under external ear problems on the blueprint is external ear trauma. And I wasn't exactly sure how to address this. I think this is new to the blueprint because I don't remember this being in it before. And as you look it over, basically, if you get a cut, stitch it up. The one thing that did stand out was the cauliflower ear. So if you know anyone my nephews are wrestlers or a boxer, they wind up with these weird looking ears if they don't wear their headgear. And that is a result of trauma to the ear. But what really happens is they get a little bit of a bleed in there and it creates a hematoma. The hematoma builds up and creates pressure. And you get that pressure builds and it stops the blood flow from coming in. And that leads to avascular necrosis of the cartilage. And that's where you get that weird looking cauliflower ear from. It's a avascular necrosis of the cartilage of the ear. Again, how are they going to ask you a test question on that? I have no idea. I'm not too worried about it. I do think you should read through it, listen to it like we just covered, and then move on. I don't think there's anything there to highlight. I don't think there's anything there to put on an index card and study. I think that just is what it is. All right, moving on to the middle ear and acute otitis media. So as we're talking about acute otitis media, remember, we want to learn that in relation to otitis externa. This is a middle ear infection as opposed to an outer ear infection. This typically occurs in children secondary to an upper respiratory infection. So remember, think swimmer's ear is a kid in a pool a lot, usually somebody just a little bit older, versus a young child, 1, 2, 3, 4 years old, with an upper respiratory infection who then has ear pain. That's going to be how you easily differentiate these in the office, but also how you're going to differentiate them on a test. So for kids, the eustachian tubes become clogged and then bacteria find a nice place to settle in and build their little homes. The most common pathogens here include strep pneumonia, strep pyogenes, and Haemophilus influenza. Risk factors. So anybody who smokes in the home puts their kid at an increased risk for ear infections. Bottle feeding can also lead to an increased risk. I think it has to do with the angle that the kid's laying at when they feed, something along those lines, I seem to remember. And then daycare puts kids at an increased risk for ear infections. Don't know why I blanked out there for a second. One of the things I wanted to point out is I come across a thing like daycare puts you at increased risk for ear infections. And I want you to note that, again, I don't think that's something to memorize. I don't think that's something to highlight. I don't think that's something to write a bunch of notes about. Daycare puts you at risk for all pathogens, right? You put a bunch of kids together, have them playing with the same toys, licking the same toys, passing them around. This puts everybody at increase in rate of infection for everything. So yes, does it increase the risk of otitis media? Certainly. But do you need to remember that specifically? Not really. I don't think that that's necessary. I think that's just something that sticks in your head and you hold on to, as any kid in daycare is at an increased risk for pretty much every infection, especially when it comes to a test question. That's just not that complicated. When my kids were little, until my little guy got through kindergarten, we were all sick all the time. My mother-in-law was scared to come to the house. She thought we had mold. She thought the garage kept the house too cold, all these things. She'd bring holy water over to the house. And I tried to explain that it was just that they were in daycare, and I pretty much believed it. But at some point you start to get tired because we were just sick all the time. But amazingly, my little guy gets out of kindergarten and we all got healthy again. It was like a miracle. So just something to keep in mind. You don't have to memorize each and every little fact if it's a part of a larger idea. And the idea that daycare causes people to get sick is, obviously a much larger idea. Clinical presentation. Kids will come in complaining of ear pain, fever, irritability, and decrease in hearing. Something to highlight here, especially for your practice, irritability is a major one. My kids would not have fevers, would not have problems. They would be cranky and annoying. And my oldest would be cranky and annoying for a couple of days. And my wife and I would be like, man, what's wrong with him? He's such a pain. What's going on? And then we'd take him to the doctor and he'd have a double ear infection. So eventually we started to notice when he became a huge pain in the butt, we would just bring him to the doctor, and in 9 out of 10 times he'd have something. So that was his presenting sign, was he was just cranky. And that tends to be pretty common. That's very common. But the fever, ear pain, certainly. How does a 1-year-old show you they have ear pain? Well, they hold their ear, right? They cup it, they put their fist next to it. And then a decrease in hearing if it's really bad, but you're not really going to test that in a 1-year-old. It's going to be difficult. Lab studies and physical exam findings. The tympanic membrane may show erythema, bulging. The light reflex may be lost, and decreased mobility with a pneumatic otoscope. Treatment. Give the kids painkillers. This hurts. So acetaminophen, ibuprofen, that sort of stuff is very, very nice of you. Antibiotics, amoxicillin for 10 days. Amoxicillin for 10 days. You can also get a chronic otitis media. This is a recurrent acute otitis media, so it comes and goes. You get a rupture of the tympanic membrane, and here the bacteria are a little bit different. You get Staph aureus, Proteus, and Pseudomonas. For our clinical presentation here, this would be, you can get pus coming out of the ear. Yeek. You can get hearing loss. And this tends to only really be painful on exacerbation. So not all the time, it's just with that flare-up. Labs and studies, you can get that pus may or may not be present depending on when you're seeing the kid, and they will have a ruptured eardrum. Treatment. Definitive treatment is surgery to repair the eardrum. Routine cleaning of the debris from the ear, that's by a practitioner, not by the patient. Antibiotics. Mild cases can get Cipro drops. More severe cases will wind up with oral amoxicillin. The next one's a little bit weird. It's a cholesteatoma. This is basically a skin cyst in the middle ear that's filled with keratin. So this one's kind of strange because it's a cyst in the middle ear, which is a pretty small space and can cause some real issues. You can get unilateral hearing loss. Again, unilateral hearing loss. Well, that makes sense, right? This can be in a column that says if someone comes in with unilateral hearing loss, then this is one of the things on the list, but I wouldn't necessarily memorize it as it pertains to this diagnosis, because if you have a cyst in one ear, it makes sense you'd have unilateral hearing loss, right? You can get a discharge from that ear. Usually the ear is filled with debris. The ear canal is filled with debris, just skin cells and yucky stuff. And a discharge from the defect in the tympanic membrane is also visible. Treatment. Surgical removal of the cyst is going to be the definitive treatment here, but it's difficult because there's a lot of delicate structures in that middle ear, so you got to be very, very careful. But that's the treatment. And then our last one for today is tympanic membrane perforation. Again, memorizing all this, I'm not sure how that's going to help you, how much it's going to help you. I think this is something you listen to, you observe, and then you sort of have a good idea what you would do if you saw it. And you picture what you would do if you saw it in the office, and you go from there, what you think would happen, what you think might cause this, and then you're pretty much going to be right on this one. You know, when you have to do that for congestive heart failure, that may be difficult. But for tympanic membrane perf, you can probably come up with some of these. So a direct blow to the ear is one. A skull fracture is another. Foreign object pushed into the tympanic membrane, like a Q-tip. Otitis media can cause this. A very loud noise, like an explosion. Barotrauma can cause this. A clinical presentation. Again, what do you think it's going to come in sounding like? What do you think the patient's going to be complaining of? Well, they're going to have conductive hearing loss. They could have tinnitus. They can have an earache. They can have discharge of fluids, and they can have bleeding. Remember, we have trauma here. On physical exam, you can see the ruptured eardrum, right? Not a lot to go through there. And most of these will heal on their own within a couple of weeks. Patients should probably avoid submerging their heads in water. Obviously, this can lead to increased risk of infection, and a surgical repair may be necessary, depending on what, if it doesn't heal right or whatever. Okay, so again, I want you just to think about how these relate to each other. If you're asking a question about the ear, how will it come up? What are they going to ask about? What are they going to try to get you to diagnose? What are they going to try and get you to treat? That's what you should be thinking of as you study this stuff. They're not just lists of words. They're lists of words as they relate to an exam that's coming up. They're a list of words as they relate to patients that are coming through your door. They're not just lists of words to memorize. That's not our study tip, by the way. We have I'm just did a bonus. Our study tip for today is to create your own diagrams. And what I mean by that is we talk in this show a lot about active versus passive studying, a lot about how you need to be involved, how you need to be up and moving, how you need to be using your brain to think as you go through this stuff, and just looking at it isn't enough. In our interview last week, that was a major point, that just watching someone else do the work and then seeing it on the screen and say, yeah, nodding along, oh, that makes sense, that's not enough. You've got to go one step further. You've got to be more active. So creating your own diagrams is a great way to be more active. And one way I do that with my kids, when we're studying the states and the state capitals and stuff, but one of the ways I came across that's really, really simple now to do is to take a scan of a picture in a book that is labeled and you scan it in, drop it in your computer, and then use Keynote or PowerPoint and then you drop colored rectangles on top of the words, and then you have a blank image of what you were working with. So you just print that out, and then you have a really nice non-labeled image to go ahead and label. This takes a few minutes now. It used to be a little bit more of a pain in the butt when I was in school, but now it's really, really straightforward. It's really easy. Only takes a couple minutes, and you can create these beautiful diagrams, and then you have answer keys and a beautiful diagram to label right there. Something like that's extremely helpful for courses like anatomy, obviously, but can be helpful in lots of different places. So it's something to consider, something to think about. Really easy to do. I know we used to draw tons of things on the whiteboard and cover the boards in different diagrams. I wasn't someone who could draw, so that was always more frustrating to me than it was helpful. But doing this is a way you can sort of do the same thing and come up with some great results. All right, so let's finish up and talk about our priming questions, get the answers in case you didn't pick them up as we went through. What is the most common cause of otitis externa? What was the bug that was the most common cause for otitis externa? Pseudomonas. Name the 3 most common bugs that cause otitis media. The 3 most common bacteria that cause otitis media. Do you remember? Pseudomonas was in the water, right? Our swimmer's ear. That's always an easy one. I always think of hot tubs when I think of that. I think of post-op knee patients who go in the hot tub too soon and they get Pseudomonas infections. I don't know why, but that's what sticks in my head. So whenever I think of a hot tub or water infection, I think of Pseudomonas, which helps in this case. Name the 3 most common bacteria that cause otitis media: strep pneumonia, strep pyogenes, and Haemophilus influenza. And then what is our first-line antibiotic for otitis media? It's going to be amoxicillin. Amoxicillin is our first-line antibiotic for otitis media. And if you look at it, I only came up with these 3 questions on this section, and I spent a little bit of time. It's not like I just blew through it. Trying to come up with useful questions, and they were on otitis media and otitis externa. What was I going to ask about cerumen impaction? What was I going to ask about tympanic membrane rupture or cholesteatoma? I mean, I guess I could find something there, but I don't know. To me, when I'm working, I'm focused on a couple topics. I'm not doing everything all at once. It's just too much. So I try to look for the most relevant, most important things and use the 80-20 rule to sort of work out what may be more useful. Anyway, that's my 2 cents for today. Next week, we're going to move on to the inner ear, cover some hearing loss issues, and talk about that kind of stuff. But like I said at the beginning, I wanted to thank each and every one of you for showing up, for taking part in this, for being part of this community. There are literally thousands of you out there who are struggling, who are looking for ways to improve. And I'm so grateful that you come here and support me in what I do, so that I can support you in what you do. And like I said, the iTunes reviews, the emails, everything has been really, really marvelous. Really wanted to thank you for that. So without further ado, if you are fortunate enough to be taking your test, I think there are some people who are actually taking tests right now. It's few and far between, but if you're fortunate enough to be doing that, please let us know how that goes, but also good luck to you. And I will look forward to talking to you again next time.